all these disease processes and what we're gonna do for them, and the treatments. I feel like that, some of this stuff is a lot more common, so you guys will see this pretty frequently for these. All right. So obviously we're gonna cover our anatomy here. We're just gonna talk about, the layers and the muscular structure we have in the colon. And these kind of help us, like the tinea go the whole length of the colon except for the appendix and rectum. So these kind of help us identify where we're gonna do surgery at in the colon. And then obviously you have your haustra, which is it has your circular muscle, and this is what helps move all your food through the GI tract. And it's important to consider which ones are where. So obviously we need to know where all the retroperitoneal organs are versus our intraperitoneal. So and this just had different meanings, especially as we talk about trauma in the later sections. This becomes important on where we think something can be injured. It's also important for our medical treatment as well. So, the ascending colon to the hepatic flexure is retroperitoneal, and then you get your transverse to your splenic flexure, which is intraperitoneal, and your descending, which is retroperitoneal. And then it's important to remember the sigmoid, is particularly prone to volvulus. So that's more commonly where you're going to see that. And then we obviously have our rectum and our anal canal. All right, diverticulosis. So this is pretty common, especially as we get older. And basically what it is you get these small outpouchings through the colon. They typically, depending on where it's located, typically in our society it's on the left side, so it typically doesn't involve the muscle in that area, but it's just some form of outpouching. And the problem is you can get bacteria or food stuck lodged in there, and it creates an infection, and that's when we start to have symptoms. It can also cause bleeding as well, which we'll talk about here. And then they do classify them whether they're pseudo diverticular versus true. It's not really something we focus on, but more predominantly in the right colon, which we don't see as frequently, they call the true diverticula because it involves that smooth muscle. All right, and then let's talk about some inflammation here. So this is very common, like I said, as we age. We actually used to only associate with they're over 50 or at least 40. I mean, I've seen it in 20-year-olds now, so it is becoming a lot more common and prevalent. You see it a lot more in the elderly, and most of the time it's on the left side, and it involves the sigmoid colon, so it's an outpouching there. And then when it becomes symptomatic, typically they'll have some sort of, it causes inflammation, they'll have that pain, they might have a fever. You can also get bleeding from it, but they're usually not in a lot of pain, so this is going to be typically your more asymptomatic hematochezia patient. But when you have these outpouchings, you're going to find them all the time on CT scans, but the patient doesn't have any symptoms. So you'll see it asymptomatically all the time, and then obviously it becomes an elevated risk once they start to get disease, or a lot of times we say constipation and low fiber diet is positive. Actually, the studies don't bear that out, but we assume there is a role of at least a high fiber diet can maybe protect them against complications from it, but it's not panning out like we thought it was originally. NSAIDs play a role as well, especially for bleeding. And then obviously our complications with diverticulosis are what we're concerned about, so our diverticulitis, hemorrhage, can cause a stricture and fistula as well. So diverticulosis is the most common cause of lower GI bleeding. However, most GI bleeding, like we always say, what's the most common cause of lower GI bleeding? It's upper GI bleeding, which we'll talk about some of the percentages on the next slide. But you just have thinning of that outpouching, and then it makes it vulnerable to bleeding if they're taking any sort of anti-inflammatories or anticoagulants. We need to be concerned about that. It's also associated with hypertension and ischemic heart disease, elderly. And they'll typically present with just bright red blood per rectum, typically no abdominal pain. And the good news is most of these stop on their own. So what we do for these is just like every patient, are they stable or unstable? Do we need to resuscitate them? Usually not, but sometimes, depending on the comorbidities they have, they may come in pretty sick. And then we don't normally operate on these unless they're recurrent. So typically the first bout we don't do anything for. Now if they have multiple episodes, and we can find the location, which we'll talk about, and that becomes the difficult part, is finding location of the bleeding for these patients. So like it says on there, 20–30% have major GI bleeding from a lower source. Most commonly it's from an upper source. And this bleeding is going to be distal ligament detritus, which is why, the colon's pretty long, so it can be difficult to locate the area, which is why it's a little bit harder to do surgery on them if we can't find it. They can have occult bleeding, so that's that little hemoccult card where sometimes you'll do a digital rectal exam and you'll have to send one of these cards. We used to be able to do them at the bedside, but apparently we're not competent enough, so the hospitals have banned us from doing them at the bedside. But you do want to check for, like I said, hemodynamic compromise. A lot of times we want to get like a CBC on them, just checking the blood count, looking at their hemoglobin and hematocrit. And then we need to assess them and actually do, a rectal exam on all of these patients. And typically when it's bright red, we think more of a lower GI source. So that, we don't want to assume they're all hemorrhoids, which usually sends you, can get you in a lot of trouble if you just think it's a hemorrhoid. And then if it's melena, which is black tarry, that's typically from an upper GI source. You got the breakdown of your hemoglobin in the GI tract, and then it causes that like dark melena, foul-smelling stool. And that's usually going to be for an upper GI bleed. So we do always have to investigate it. We want to do a rectal exam on them. We want to look for any sort of gross bleeding on rectal exam. If you have an anoscope, great, we can use an anoscope. A lot of times we don't have them readily available. But if we're suspecting that this could be from an upper GI source, a lot of times we'll do an NG tube lavage, just looking for any sort of clots or any upper GI bleeding. And that can help guide us on whether we think they need like some sort of endoscopy versus a colonoscopy. But the treatment for these, if they don't improve on their own, are going to be some sort of colonoscopic therapy, which is going to be, they can do injections, they can do fibulations, chemical therapy. Sometimes we'll use angiography with embolization, IR procedures for these. Oh, ooh, wrong button. All right. So obviously when we resuscitate them, there are some other testing we can do on there, like if they have a negative colonoscopy, like we do tagged RBC scans. CT angio is typically the quickest and most readily available test we can use on them. So we'll typically get a CT angiogram, which can look at all your vasculature. So really it's just a time study, like with contrast, like we normally do for patients. And then they just look at the timing in the vessels, and that's when they do the actual scan, and so we can better evaluate on where that bleeding is coming from. Indications for surgery are if they're unstable. Basically, they require multiple units, typically more than 6 units in 24 hours. Or if it's any recurrent bleeding, then we might take them to the OR. And then when we do that, if we, once we've found the site of the bleeding, we'll do that, usually a segmental colonic resection versus a total colectomy. Alright, so diverticulitis. This one's very common. We see it quite frequently, and this is just inflammation of that little diverticular, the outpouching. I get some sort of stool caught in there, leads to inflammation. We call it uncomplicated if they don't have an abscess or there's no perforation in there. So that's kind of how we risk stratify these patients, but all of them usually get a CT scan for diagnosis. And when they present, it's typically that left lower quadrant pain. They'll have a fever, typically irregular bowel habits. Depending on where it's located, they could have some urinary symptoms on top of that, but typically localized left lower quadrant tenderness on your exam. They may have guarding or rebound tenderness. And sometimes you can feel a mass, sometimes you can't. And then typically when we get that rectal exam, we want to check for any bleeding as well. But typically the bleeding is associated with diverticulosis and not diverticulitis, but there can be some like microscopic bleeding where there are traces of blood. And complicated is when we have that abscess, any sort of obstruction, perforation, and those ones typically are going to get antibiotics, bowel rest, they'll be admitted to the hospital. Larger ones may need to get like a percutaneous drainage of that abscess, just like we do on the skin. The best treatment for an abscess is remove all that fluid and bacteria from there. And then we can get, multiple types of fistulas from these. Not as common, but it can happen depending on where the location is. So if they, if they get like pneumaturia, or they have any sort of like feces in their urine, these can be other signs that there might be like a colovesical fistula, versus like you can get a colovaginal fistula as well, so you can get like gas or stool through the vagina. They may complain of like foul-smelling discharge. It might, typically not painful. And then if there is a perforation, that's going to be usually your septic patient with like general peritonitis. They're going to have left lower quadrant pain, and that's going to be an indication for an emergent surgery. So CT is the best test. CT abdomen and pelvis with contrast is what we normally do for these. And you'll usually see some bowel wall thickening. You'll see the diverticulosis. Hopefully diverticulitis. You'll see some inflammation. And what we worry about, we got to make sure it's not an abscess or that it hasn't ruptured. And then the key for this one is this. You guys will see this, and the key is when they need the follow-up for their colonoscopy. So we typically want to wait till all their inflammation has resolved. So we typically send them for a colonoscopy 6 to 8 weeks after the episode of diverticulitis. So it's important to remember that, especially when you're seeing these patients that they need a colonoscopy, but not immediately, because you run the risk, they have a high risk of perforation if you do the colonoscopy immediately. All right. So we just talked about, they need a CT abdomen pelvis with contrast for these patients. So what is the treatment for these? So if it's uncomplicated, typically we give them bowel rest. There's actually evidence now, some places are doing it, we don't do it, where they actually don't think antibiotics actually are required for uncomplicated acute diverticulitis. So you see some evidence for that out there now. We're typically still giving antibiotics for it, and most commonly we're giving Augmentin. Ciproflagyl used to be the standard we gave everybody, and now we backed it off a little to just Augmentin. It's a lot easier to take, and it has less less side effects than like your Cipro will. And then we need to, after we treat them, we need to have them follow up with colonoscopy in 6 to 8 weeks. And then typically we keep them in the hospital if they have an abscess, any sort of perforation. And then this goes for any patient. Anybody that's not able to tolerate anything by mouth, they need to be admitted to the hospital. So that's for every patient, but especially these ones. If they're if they're not able to take anything by mouth. And then depending on the comorbidities they have, it may be a surgical candidate. Typically, surgery is reserved usually for recurrent episodes. All right. So recurrent diverticulitis, these are typically it's an elective procedure, and this is after multiple episodes. We say typically after 2 episodes, we'll refer them for surgery, and they can evaluate whether they want to do a colectomy versus other procedures to help improve the symptoms, so they don't have these recurrent episodes. But we need to wait for them to obviously the inflammation to resolve first. So non-op treatment, 80 to 85% successful, works well. Even with recurrent episodes, non-op treatment works great. It's just they end up having an episode further down the road, which is why we take them to surgery. And then there are the different procedures we can do. And we do a Hartmann procedure, which you can see in the picture there. They might get an anastomosis with diversion or without. So there are a lot of different options we can do for these. And you guys, it's not important to know all the procedures we do. Just know what we do for these recurrent episodes, or if they fail non-op treatment, that they need to be referred to surgery. All right. Is this patient stable or unstable? Yeah, it's going to be unstable. So what do we do for those? What do we have to do first? Yeah, we need to get fluids. In this patient, we have a UA with bacteria and white count, so likely a uroseptic type picture for this patient. So they need IV fluids and antibiotics immediately. All right, let's talk about cancer. So colorectal cancer, very common. It's like the third most common in incidence of mortality. Typically elderly patients, a little bit younger in men versus women. And then there are like multiple risk factors for this. Obviously, alcohol and smoking are always a risk factor for I feel like any type of cancer. But they also can have family history as well, can play an important role in other types of cancer. If they have other types of cancer, that's going to be a concern too. Or adenomas are the most common. So what do we typically see is, so the reason we send them for the colonoscopy, just obviously even for our regular US whatever screening, preventive health task force screening, this is why they recommend getting a colonoscopy, just as we age we run a higher risk. And what we tend to find are a lot of polyps in the colon. So typically they'll have to be removed, biopsied, and we send the pathology, and then we'll decide whether it's malignant or not. But, like it says, less than 20% of polyps are malignant, but we still want to make sure we refer them for colonoscopy so they can evaluate this. And then what we get concerned about are anything that's large, so over a centimeter is going to be a concern, and then certain histology is concerning as well, which is not something you guys need to memorize the histology, just understand that, we need to do a polypectomy, and that these patients, need to be screened, they need to send to pathology, and then they may or may not require like a surgical resection if it is confirmed to be cancer. And then obviously there's other cancer screening guidelines as well. This one's the Multi-Society Task Force. And they just go through these different tiers in the systems, and we kind of look at risk factors and when we should do the colorectal screening. So average is usually initiating at 50 years old. If you have other risk factors, it may lower it down to 45. And some may even have 40 years old. All right, so what's the clinical presentation look like? Most commonly is going to be some sort of colon obstruction. So, this is going to be typically left-sided. They're going to have possibly bleeding. They're going to have nausea, vomiting. They're going to be sick. And some of it depends on which side of the colon it's on, but like most commonly for us, it's going to be left-sided. And then we'll have to resuscitate them. We obviously want to evaluate whether they have any rectal bleeding, which is a very common complaint with colorectal cancer as well. All right. Yeah, so it's going to be colorectal, since we just talked about it. No, and this one, obviously, they have some sort of tumor there, so that's why they have those pencil-thin stools causing, it's almost causing a complete obstruction, but not yet. So this is what's going to, in our history, and with the blood, it's going to lead us more towards maybe this is some sort of malignancy versus like a diverticulitis or any of the other causes of lower GI bleeding. All right, so what else do we need to do for these patients? So obviously we need to get labs on them. So, commonly, can be suspicious for malignancy is like an iron deficiency anemia. We do want to look at some of our tumor markers as well, like to have a CEA on there for post-op monitoring, but we typically look at CBC, CMP, chest x-ray. Why are we doing the chest x-ray? Yeah, looking for mets. And then, based on the exam and biopsy results, we'll typically do clinical staging and then decide what kind of procedure they're going to need for this. And then obviously if we're concerned for mets anywhere else, the chest x-ray is nice, but typically we'll get a CT scan or MRI as well. We can get PET scans too, but typically at that point they're likely being managed by subspecialty. What do you guys think? Yeah, colonoscopy. And then we have, you guys don't need to memorize the different stages of colon cancer. Just be aware we do our normal TNM staging, just like we do for all the other cancers. And then we just, based on what stage they're in, it helps kind of guide what we think our cure rate's going to be for these patients. They are going to need lifelong follow-up and screening, just because of the, recurrence can be high, and especially depending on which procedure they got and whether we excised everything. There may still be a tumor left in there. And unfortunately, a lot of times we do our regular screening and we don't catch it until it mets to somewhere else, which is, unfortunate. Hopefully there are some newer tumor markers out there we're studying now that hopefully, they seem to be doing really well. They're just expensive right now. So hopefully we can make those widespread and catch this a lot sooner. And the different, we have our curative versus palliative. So typically if it's already metastatic, and depending on where it's, how large and what the extent is, and where it's mets to, like they may only, we may only be able to do a palliative therapy for them. Curative, typically we can remove all the tumors and nodes prior to them metastasizing. So we catch it early, that's great. That's why we do the cancer screening starting at 50 or earlier. And then if they have any of those familial disorders like polyposis, they will do, we do consider prophylactic colectomy in those patients. And then if, depending on tumor size, we may have to do like neoadjuvant radiation or chemotherapy for them prior to any removal of the lesions. And like I kind of already said, it obviously depends on the extent, the size of the lesion, the staging we do, and how much, how large of a surgery it's going to take. So, the goal is hopefully we don't have to remove the entire colon, because then they'll, have to have a colostomy bag for the rest of their life or some sort of other procedure. So we try to spare as much as we can, but these are our different options depending on where it is and what we're going to do. So some, if it's sigmoid, a lot of times we'll take out the entire sigmoid, or we'll do it like a left versus a right hemicolectomy versus a transverse. So and here's even more, like we can do an abdominal perineal resection. And this just depends on how distal it is in the colon. Like if it's in the rectum, this is an option for the surgery that we're doing. But it's just something to be aware of. Obviously location dependent on what our surgical options are. And what did we talk about was curative for these? Obviously removing it, so surgery, yeah. Anybody choose 5? Just follow them up. Repeat colonoscopy. Alright, so colon obstruction. Colon cancer is obviously the most common cause of this, and this is going to present similar to your other bowel obstructions. Typically pain from some sort of mechanical obstruction. And then they may have an ileus versus a complete obstruction, so it's always important when we evaluate these patients. Then we need to look at what sort of past medical history they have. Is this in the post-op setting? Did they have any sort of prior surgeries in the past? Which is important to consider, but typically they're going to have the nausea, vomiting, abdominal pain, and distension. So if you have like colon obstruction, you should always consider some form of colon cancer. Obviously, patient history is important in their age. but you may see a volvulus and a large bowel obstruction, which is just twisting of the cephalosigmoid colon. And then these ones are going to need, typically we'll need a colonoscopy, but we need to evaluate them for an abscess. We're definitely going to get CT scans on these to evaluate. We do have to rule out other causes as well, because we have so many different things we can have in our belly. And then obviously in those little kids, we need to consider Hirschsprungs as well. So that's when you have that massive amounts of stool in the dilated colon, and that's when your sphincter doesn't relax, and so the stool can't evacuate. And that's going to require surgery, but that's typically going to be in your younger patient population in childhood. And then what's on the differential? So obviously our inflammatory bowel disorders are something we need to consider for these. And this is especially in like our younger patients as well. This is where we see this more commonly. So they may have an undiagnosed Crohn's disease or ulcerative colitis, but really, one of them only involves the colon, then obviously the other one can go from anywhere from the mouth to anus, and they all have significant complications associated with them, which is why we always need to consider some sort of inflammatory bowel disease when we have an obstruction. So in the right patient population, I mean, typically they're going to be younger and undiagnosed. So this is something we need to be concerned about. And then, how do we tell the difference between ulcerative colitis versus Crohn's? So the question is, are they going to present completely differently? Probably not. Most of them are going to present the same, which is why a lot of times we just lump it into inflammatory bowel disease in the acute presentation. So, they say like ulcerative colitis may have, proctitis with it or pain with defecation. Typically, bloody stools are found more commonly with ulcerative colitis. And then they're going to have more systemic symptoms with Crohn's disease. And then obviously they can have all kinds of other effects with it. You may have extraintestinal manifestations, which are commonly seen as well. So we need to make sure we're doing thorough evaluation. Most of these patients are going to require surgery. However, we catch it in usually the acute phase, and we further evaluate them to get this diagnosis. What do you guys think, Dave? And like we said last time, rectal bleeding, we think of that more commonly with ulcerative colitis, and then some of the other complications we'll see more with ulcerative colitis as well versus Crohn's. So what do we do for these ones? Pretty much the same thing we do for, a small bowel obstruction. We're obviously going to resuscitate them first. We'll likely need to give them some sort of maintenance fluids as well if we're going to admit them. All of these are going to be NPO. We place the NG tube in for suctioning. And then we need to further evaluate them on whether they have any sort of necrotic bowel, whether we see a perforation. This is typically with our CT scans. We don't typically do barium enema anymore. And just because, especially if they're, if we're worried about any sort of like perforation, this can increase that risk if we're going to put any sort of fluid in there. So we typically don't do the barium enema, but the CT, the abdomen pelvis with rectal contrast can be our most useful test if they're stable, and we don't suspect any other conditions of the colon. We can call the gastroenterologist and refer for colonoscopy. So that's only if they're stable. Typically, we'll admit these patients to the hospital, and then gastroenterology will follow them while they're admitted and decide whether they need to do a scope or not. Yeah, we probably don't want to give them laxatives, right? That would cause more harm than good in these patients. Everything else is certainly an option that we typically do when we admit these patients. We may or may not give antibiotics depending on if we have a risk for bacterial infection.
Would you want to give an antibiotic?
Yeah, we give an antiemetic, yeah. Yep. And typically, like, so when we initially treat them, they'll be PO intolerant, they'll have the nausea and vomiting. So we'll start with an antiemetic. Obviously, we'll get labs, get some fluids on them, and then we'll, decide whether we need to do any imaging on them. If the antiemetic, is not improving it, and we get imaging with a bowel obstruction, then we'll typically put an NG tube down after that. But we typically start with antiemetics. And that's most commonly like your Zofran. Good old hemorrhoids. So this is very common. You guys are going to see this a lot. And, you're going to have varying symptoms with these, but depending on whether they're internal or external, this is why our rectal exam is very important. And it's also important not to assume all rectal bleeding is a hemorrhoid. So you should assume it's, from another source and convince yourself through your exam and your laboratory findings that it's not any sort of hemorrhoid, or that it is a hemorrhoid. So basically, you have to prove that it's not an emergency, and then you can rest your diagnosis on hemorrhoids. But we have two different types, and whether they have symptoms or their location is what's going to cause the pain. So some of them may have pain, irritation, they may say itching. Most of the time they'll say, I had some blood on my toilet paper. And especially, I don't know what it is with like younger men, they're just like super scared and they show up all the time. One little drop of blood on their toilet paper, they're in the ER. And they're like, there's blood on my toilet paper. I'm like, okay. And typically you'll typically diagnose a hemorrhoid on them when you evaluate them. But sometimes it's hard, especially for the internal hemorrhoids. On your evaluation, it's very difficult to see those. If you have an anoscope, it works better. But typically they'll have that bleeding, protrusion, and pain with it. And what we have to do is decide whether, we have to evaluate and decide whether it's thrombosed versus just like your uncomplicated hemorrhoid, because our treatment can be a little bit differently, and our time frame of therapy is a little bit different as well, depending on how acutely they present. So typically, like I said, painless, bright red bleeding, typically on the toilet paper, or they may have like a squirt into the toilet. That's another common one. They'll say there was some blood on the side of my toilet. And depending on how long they've had it, it can be significant bleeding as well with some of these. So if you're concerned for bleeding, obviously getting like a CBC and looking at their blood count might be important. Now, if we're worried about whether it's thrombosed, that's typically going to be severe pain. You're going to see that purple, it's going to look like that one. And that one typically, if it's in the first 72 hours, we can treat that a little bit differently. And it usually is amenable to like evacuation or clipping. So we can actually remove those if they present in the acute period. Unfortunately, a lot of patients don't present acutely. Some do, but typically when it's thrombosed, they've usually had hemorrhoids in the past. We see it a lot of times in pregnant females, and they'll usually present a little bit later because they've been used to dealing with it. So sometimes we may or may not be able to do a procedure on them to help. And then you obviously need to do your digital rectal exam. Most places, some places might have an anoscope. I've never had any where I've worked an anoscope, but some people have said they have them in their clinics and their ERs. We've never had any. But that can be helpful too, because when you have the internal hemorrhoids, obviously just on palpation, it's kind of hard to evaluate. And then we have our different grading for hemorrhoids. So, one is no bleeding, no prolapse, and then you have your prolapse with Valsalva or some sort of maneuver, or you can reduce it. And then you have your prolapse with Valsalva, and you have to manually reduce it. And then you have your incarcerated, which is when we look at treatment. That's when we look at it being thrombosed. So basically, blood in the hemorrhoids clotted. It looks like that purple marble in the first picture on the anal verge, and it's extremely painful. So what do we do for these? Most of them, we give them a stool softener. We can give them some Colace, Metamucil, whatever we have. Sitz baths are one of the things we prescribe them. Topical lidocaine jelly works well, just to help numb the area. We can get, there are some of the ointments out there. They're not as common, like the the nitroglycerin and the calcium channel ointment. But that can help relax the sphincter and cause some relief for the patient. You can give them those like the anti-inflammatory wipes. I think they're like witch hazel is what's in them. Typically, we tell them to increase the fiber in their diet. We give them education on not like straining on a toilet. Don't take long bowel movements. Don't sit there on your phone to help avoid this. There's also some other ones like Proctofoam's another common one we give, which is it's a steroid and an anesthetic in one. So that's nice to give. This is expensive, so some MTFs don't have it, some do. It just depends on where you're at. And then if we have thrombosed hemorrhoids, this is when we can actually treat them in the acute period. So there's a couple different options. We have like sclerotherapy, which that's an option probably in a surgery clinic. I've never done that one. Or you can have like band ligation. All right, so we have our excisional hemorrhoidectomy. So obviously this is like when you have your, this is when you refer them if they have chronic hemorrhoids and they've had multiple episodes. You refer them to the surgery, they do an elective procedure with the excisional hemorrhoidectomy. For the acute period, when they're thrombosed, these ones are going to need surgical excision of the clot. So this one's typically, a relatively minor procedure. And then the key is, though, we have to do it within the first 72 hours for it, to avoid recurrence. So if it's not within the first three days, like if you have an acute patient with hemorrhoids, it's purple, it looks like a little marble, it's thrombosed, but they're not within that first 3-day window, then they're not going to be amenable to surgical excision. So that's not, we have to make sure we have the right history for this. Rectal prolapse. Ew, it's gross, right? So this basically, obviously, you have, protrusion of the rectum through the anus. It can, we see it more commonly in females, postmenopausal, and typically patients with constipation. If they had any surgical procedure, anorectal surgical procedures is something to think about, certainly as well. But as you can see from the appearance there, you'll have basically the rectal mucosa outside of the rectum, so you'll have that like circumferential concentric folds. It's usually pretty prominent and hard to mistake it for something else, but sometimes it could look like a hemorrhoid, depending on how bad the prolapse is. And we typically have two categories of procedures we do. Is we do perineal abdominal. You guys don't need to know any of the procedure, just know that we do have treatments for these. And then neoplastic lesions. This is actually not very common, but it is something we do need to consider. So they could have squamous cell carcinoma at the anal margin. Typically not associated with any metastases, but they usually have pain, bleeding, pruritus, tenesmus, might have incontinence. As you can see on the lesion there, it has like the rolled everted edges, central ulceration. And this is going to need to be excised. We're going to need, wide margins. And then if it's poorly differentiated, once we remove it, then they may need to get some chemoradiation. There are other procedures. If it's recurrent, like, they could get an abdominal perineal resection, but not very common. So you can have carcinoid tumors, which is most common endocrine tumor there, that you can have in the anal margin, and this is going to cause other symptoms. That's why it's neuroendocrine. So you'll have those hot flashes, bronchospasms, arrhythmias, and then these ones have a smaller risk for metastases. And then we also have to worry about lymph node involvement for these as well. So these have a high incidence of having positive nodes with it, and they can have different carcinoid syndromes too. Oh yeah, this one's gonna be 3, colonoscopy, so they'll have to, they'll have to remove the polyp and send it for, to pathology. And then they can also do a biopsy as well if they see some malignant tissue while they're doing the colonoscopy. And then, so this is, another common complaint you'll hear typically with bleeding of the rectum. So you'll have like your hemorrhoids, and then you also have, now if you have a hemorrhoid with significant pain, especially during defecation, this, we need to start thinking about an anal fissure. So it's a small tear in the anal canal to the dentate line. Most of them are posterior, so it's always good to remember that. Like I've seen that on board questions. What's the most common location for an anal fissure? So it's typically posterior midline. And then we typically categorize them as acute versus chronic. And so, they might be a small tear that's amenable to medical treatment versus like a chronic fissure, which can lead to an ulcer, which is going to typically have like prolonged periods of pain. And they'll typically require a little bit more medical management to heal, but in the acute period when we see these, we can typically treat them with some of the medications we'll talk about, some of the similar ones you use for hemorrhoids. But the concern here is we have to think about inflammatory bowel disease with these patients. So we need to make sure that they don't have any inflammatory bowel disease. And then we need to think about their sexual history, travel history as well. So there are some other causes that can be associated with this. Typically, it's from usually like some sort of large stool, and they come in. They have every stool after that is extremely painful with a little bit of blood on their toilet paper is the most common presentation. Typically, it's from, like I said, straining. I've never seen it from heavy lifting, but I guess probably there from that. But typically from constipation is the most common. All right. So yeah, typically that acute pain after a stool. They'll typically have some blood on the toilet paper. A lot of patients will think they have a hemorrhoid and they'll present with that. It's usually pretty easy to differentiate when you do the exam. Since most of them are that posterior midline, you can usually find the anal fissure. And then most of them are treated conservatively, so we give them topical nitroglycerin, they say nifedipine, that's, we typically don't have any topical nifedipine, or most places don't, but that is an option if you have it. And then, if the symptoms aren't resolved, you can refer them, they can get a Botox injection. And then, like operative management, which isn't, very common, but they can do, a sphincterotomy. And we're really just enlarging the area. So, I can't imagine that being pleasant. Let's talk about the abscesses. What's our time? You guys want a break? Let's do it. Okay, cool. Yeah, we're almost done. So perirectal abscess. And this is just an infection of the anal canal. You obviously have these small crypts at the dentate line. They get obstructed. They lead to a localized infection. And we basically classify it just based on the location. These tend to be extremely painful, and they can become very large. So it's important not to confuse this with a hemorrhoid, which it doesn't look like one there. So that's obviously like your classic textbook presentation. Sometimes it can be very subtle on exam, so you may just feel a small mass on whatever side when you're doing your exam, whereas that's obviously a clear abscess, but a lot of times they're deeper than that. So you do have to have some suspicion for it when you're evaluating the patient. But they're typically going to be a lot more painful than your hemorrhoids, and they're usually going to have some sort of systemic symptoms too. So they'll usually have a fever and a lot more pain than you would with any of the other rectal conditions. So this one, typically we get a CT for diagnosis on this, just so we look at the extent, and then it'll help us kind of guide whether there's something that can be drained, whether it needs to be drained in the operating room versus the outpatient setting or in the ER. But like with all abscesses, you've got to do incision and drainage on these. But the problem is that they can tend to be pretty deep. Like I said, if it's very superficial, you can drain an AED. Typically, they're a little bit deeper, so like on there it says, abscesses may heal spontaneously. No, typically they don't heal typically we have to drain them. We may have to have some sort of drain in there to keep them open. We do have to worry about recurrent symptoms or creating a fistula tract. So these ones typically are gonna require a lot of follow-up. Like it says, it has a recurrent rate of 50%, so they will require a lot of post-op care. However, it's usually simple. We don't need to give antibiotics unless we see a localized cellulitis. You might need to give them some sort of pads. Sometimes a donut can help these patients, depending on the location, so you can give them one of those donuts. And then stool softeners, laxatives, and pain meds are usually the treatment of choice. And then you can tell them to take those warm baths to help kind of relax the area and alleviate some of the pain. Has anybody seen Palmate disease? It's gross, right? No offense to anybody who has it. It looks painful. So this is going to be on your gluteal cleft. And basically, you're going to have like hair follicles that grow into the skin. They become infected. And this is going to be one, we typically will drain them depending on how bad, how significant the abscesses are large. And you tend to find, it can be kind of gross if you're not prepared for it. But like it says on here, typically you're a young, hairy male having the pain, swelling, drainage. It's going to usually be chronic and recurrent. So you may just see a tiny dimple, or you may see the entire area inflamed on the gluteal cleft. And usually that's when they present. So it'll be usually a pretty extensive area by the time they present to you. And sometimes you can see hair protruding from it. It is important in the history to figure out whether they have like a hidradenitis suppurativa, which is commonly associated with pilonidal disease. And a lot of times they'll have, these ones are usually like axilla is the most common. They'll say they have quite frequent abscesses in their axilla, and they've had to be treated for that many times in the past. And that can kind of help guide you on whether this is going to be. So one of the reasons we want to know that is because whether we think it's going to be chronic or recurrent. Sometimes this may be a one-off episode, but typically it's going to be chronic and recurrent, and they'll have to get surgery for it. But in the outpatient setting, you guys will see this frequently and have to decide whether you want to drain it or it's amenable to drainage versus outpatient like elective surgery referral. Typically, if they have any recurrence, they will need surgery for these, and typically they'll have to excise the whole area. So the issue with this is, like when you're excising, you see it covers that very large area on like intergluteal cleft. So they'll have to remove that entire area, and then it has to heal. So it's like re-epithelialize, and it just takes months of follow-up and treatment if they end up getting this procedure. But that's really the only curative procedure, and it still has. It's still going to recur even after that. So this is definitely a difficult disease to treat. Like I said, like in the acute setting, you can do an IND on these. You'll typically have to have some sort of drain in place for it. Rectal form bodies. So this is actually super common, believe it or not. Patients present with this all the time, and it can be from anything. We had like a light bulb somebody had introduced in there, and the key to this is identifying where the location is. So a lot of times we can do a plain film. Usually we'll do a CT scan, and that just kind of helps guide us on whether this is something we can remove acutely, or whether they got to go like in the ED, or whether they need to go under anesthesia for it. Unfortunately, once it's entered in there, you have like a negative suction that can be very difficult to overcome. So that's why they'll need anesthesia and taken to the OR to help relax them. What we really get concerned about, people do place glass bottles in there. They can have glass sex toys. There can be all sorts of different things you'll find. It's not uncommon. I hate to say it, I have dozens of pictures on my phone of images that I've taken of stuff people have shoved in their rectum. So they're usually very embarrassed when they come in. So, it is, you do have to kind of be careful when you're evaluating them and gaining their trust. But this will be, what I see most commonly is the patient is like their complaint is something very random. And I'm like, well, how do they come to the ER for that? Now when I go in the room, they're like, yeah, that's some stuff up there. You're like, what? And then the story comes out and you figure out what it is and evaluate it. So typically you'll start with your physical exam and then usually followed by imaging to figure out the depth of it. The last one I had was actually, on imaging, it was actually touching the coccyx, so it was actually pretty deep in there. All right. Questions y'all got? You guys just hungry, ready for the weekend? All right, I'll hang around for a minute.